So today I'm going to respond to a question that was posed to me by a 34-year-old female who's considering cryopreservation. She asked in particular, what are my thoughts on egg freezing? What are the risks, side effects, and potential effectiveness? She thought about cryopreservation in the past, however she became dissuaded given the perceived risks, and now she's considering the process more seriously. She's certainly not alone in this desire to delay the time of childbirth. In 2002, the rate of childbirth amongst women between the ages of 15 and 19 was 4.17%, and that rate declined to 1.74% by 2018. And in contrast, among women between the ages of 35 and 39, the birth rate was 4.14% in 2002, and that rate increased to 5.22% by 2016. The reason that the birth rate has increased amongst older women compared to younger women over time, that is the reason that women are delaying the time of childbirth, has been the propensity of women to pursue postgraduate degrees and the finding that women are achieving a higher rate of professional success in their careers now than they were in the past. So first I'm going to discuss a bit of the background on oocyte development. In the fetus, at 20 weeks, the female fetus has a population of between 6 and 7 million oocytes. And that population declines to 1 to 2 million by puberty, and that population declines to 1,000 by menopause, which is approximately the age of 51. And the reason for this decline over time is oocyte atresia. In particular, oocyte atresia rates increase substantially at age 37, such that between the ages of 35 and 40, the infertility rates for women increases quite drastically. In addition to a reduction in the population of oocytes over time, there's also a reduction in the quality of the oocytes over time. And this is secondary to a higher rate of aneuploid oocytes as women age, and a higher rate of acquired dysfunction in meiotic spindles as women age. Next, I'd like to talk a bit about the process of cryopreservation. The first step is ovarian stimulation, which is required in order to increase the oocyte yield. Ovarian hyperstimulation is accomplished by the administration of gonadotropins, such as human menopausal gonadotropin and follicle-stimulating hormone, or both. And two protocols in particular exist for the ovarian hyperstimulation. The first protocol, which is the long protocol, involves the use of a gonadotropin releasing hormone agonists such as leuprolide prior to the administration of human menopausal gonadotropin or follicle stimulating hormone. The leuprolide is administered so the practitioner can gain control of the cycle before subsequently administering the gonadotropins that will ultimately hyperstimulate the ovary. In contrast, a short cycle involves administering the gonadotropins, that is human menopausal gonadotropin and follicle-stimulating hormone, or both, at or during menses. And this process does not require the use of a gonadotropin-releasing hormone agonist such as leuprolide. Next, the practitioner follows the oocyte size to determine the time at which ovulation should occur appropriately. And ovulation typically is initiated when the greatest diameter of the oocyte is 18 millimeters. At that point, recombinant HCG preparation is administered, which begins the ovulatory cycle. And 34 to 36 hours after the initiation of this ovulatory cycle, a transvaginal ultrasound-guided aspiration of the ovarian oocytes is performed in order to retrieve as many oocytes as possible. The greater the yield of oocytes, the higher the likelihood of live birth for the female. The next step to discuss is the point at which the woman would like to become pregnant and have the child. At that point, the oocytes are thawed and in vitro fertilization is performed. In many cases, there are failures in fertilization, and in vitro fertilization in particular. The failure rate may be between 4 and 16%, and this may be due to the oocyte factor, may be due to male factor infertility. There are new methods in order to improve the success rate of in vitro fertilization, such as intracytoplasmic insemination, which in particular improves the success rate for fertilization amongst couples who have male factor infertility. So just a bit of information in regards to the outcomes. The outcomes are auspicious when the process begins when a woman is younger. So for instance, amongst women who begin the process at an age prior to 35, the live birth rate is 41.7%, and that rate declines to only 3.6% when the process begins at an age greater than 42. So that's a bit of information about cryopreservation. One more topic that I'd like to cover is the risks of the procedure. It has been shown that pregnancy secondary to in the process of cryopreservation does not lead to a higher rate of miscarriage, does not lead to a higher rate of congenital abnormalities, does not lead to a higher rate of obstetric complications or childhood complications than does pregnancy secondary to a normal conception. In regards to the procedural risk, in the past there was a 3% infection rate associated with transvaginal ultrasound-guided aspiration of the oocytes. Currently, antibiotics are used during the process, and the infection rate is 0%. So the risks are fairly negligible, and one of the largest concerns that women have is whether or not the process is going to be successful. It is not successful in 100% of cases, and in fact, even amongst women who are less than 35 years old, it is successful in 41.7% of cases only. That said, the procedure has improved over time. It is continuing to improve, and the number of women who are electing to undergo cryopreservation is increasing over time.